I would like to invite Professor盛望徽to the stage, and the current director of Department of Medicine of National Taiwan University. And Professor盛望徽will be sharing two interesting MNGS case reports for us, and then continue to host the panel discussion right after. Please welcome Professor盛望徽.
Thank you for your kind introduction. My name is Dr. Wang Hui-Seng from National Taiwan University Hospital. It's my honor and pleasure to host the panel discussion section. Before we enter to the panel discussion, I would like to share two cases of NGS study in my clinic and the hospital. The first, I think we had some difficult to diagnose it about parasite infection, especially in the recent biochemical, cultural, genomic, and then we found it is a very interesting case. This is the 59-year-old woman. He had a headache, progressive bradycardia for about 2 weeks. This lady had no travel history, and the occupation is only housewife. However, during the pandemic of COVID, she had cultivated a garden, and when the beginning of 20 and 22, in addition, she had raised 3 pet dogs, and then no raw food or vegetative to intake, and also no tuberculosis contact history. And also, she lived in Miaoli country with her husband and the daughter, which had no symptom. About 2 weeks ago, she had an occasional left temporal headache with paresthesia. It's like wind blow, then had a pain over the extremity. At the local clinic, and the high blood pressure was noted, systolic pressure about 180 millimeter. So at the clinic, antihypertensive medication was given. However, it is not improved. And 1 week ago, the symptom exacerbated because he had a less verbal output and a slow response to question and poor attention, and some had a memory decline. So he was visited the first to another hospital, the emergency room, where the brain CT was performed, and they showed the enhanced bilateral cavernous sinus. However, the viral infection, such as upper respiratory tract infection, was diagnosed, and then the symptomatic and the antibiotics and some of analgesic aid medications, such as NSAID and dexamethasone, was given since then. However, the symptom did not improve after the steroid use. So he visited our hospital neurological clinic, and then the neuro clinic doctor think maybe some of encephalitis involving frontal lobe. And his diagnosis is a minor stroke or a metabolic encephalopathy. And he had some of the blood tests and follow up 1 week later. However, before he come back to the neurological clinic, she was noted the conscious change drops very quickly, then was sent to our emergency department where the lumbar puncture was performed. So initially, we see the level data at outside other hospital. We can see the leukocytosis with white blood cell count about 10,000 and 2,000. And the eosinophil is about 5%, not very high. I think maybe some distorted by the oral dexamethasone or steroid use, so the eosinophil did not reflect about the disease. However, 4 days before admission, you can see the eosinophilia is much prominent. So at our emergency department, the leukocytosis, we can see the increased percentage of the eosinophil, which means a very significant eosinophilia. And this is MRI at our emergency department. You can see the very prominent leptomeningeal enhancement. So after the lumbar puncture, the routine showed the lymphocyte dominant and the glucose is normal, and there was some elevated LDH and the protein and the white cell count, and the open pressure is a little higher, but the gram stain, acid fast stain, and the antigen were all negative. We also performed the film array of the cerebral spinal fluid. Here, there were no detected. So after admission, we still strongly suggest of the eosinophilic meningitis. So we sent the NGS study, and the result was very quickly within 24 hours. And the data shows the angiostenosis cantonensis is very prominent in the CSF. And we also, at the same time, we sent to Taiwan CDC, and about 10 days, they back confirmed by the PCR study. So the patient had received very correct medication with anti-parasite, including the mebendazole, and then her family had brought the albendazole from outside country. So after complete the anti-parasite medication, the lady was recovering very well. When at the outside patient department, she can work with quadric cans, and the series and EOM is intact. And after about 100 days after follow-up, he can work without any assistance. So the second case is thank you from the Xinguang Yiyuan, Dr. Hong Huifeng from cardiologist, and the ID physician, Dr. Huang Jianxian. They had the share of the case. The case also is a female with 9 years old, and had many of the underlying diseases such as diabetes, breast cancer, and the atrial fibrillation, and he had the ICD insertion in her heart. From the May 10, she had a dyspnea and exertion for about 1 week, which was stable under regular medication before May 10. The family said that before May 14, 4 and 5 days ago, he had noted the exertional dyspnea was noted, and the body weight increased 1 day about 1 kilogram. So first, she was sent to the Wanfang Hospital, and then after they found the hypoxia and the CO2 retention, then he was intubation very quickly with a mechanical ventilation, which the cardiac echo show LV ejection fraction is about 50. After extubation, 5 days later, they had shown the pleural effusion, and they said the chest pigtail drainage, and then followed the cardiac echo very decrease to the 35%, which marks pericardial effusion. Then they discussed and referred to Xinguang Hospital on June 13. So the discharge diagnosis of Wanfang Hospital was acute decompensated heart failure with reduced ejection fraction, and had a CO2 retention after the intubation and the mechanical ventilation, and had a pericardial effusion, which means heart failure related. So this is the first chest X-ray from Xinguang emergency room, and the EKG, we can see very large heart size, which means the pericardial effusion, and the very low voltage of EKG. So at the Xinguang Hospital, there were no leukocytosis. However, the lymphocytopenia was noted, and the liver function, renal function was relative, not very good, and the sugar is not well controlled. The iron now was because she was received the anticoagulant medication, and we can see the heart failure indication is much higher. So at the Xinguang Hospital ICU, they found much pericardial effusion, then tapping about 1,000 cc of the pericardial effusion, and sent to the study. In the grandstand, they were all negative, and in the later, the culture or PCR for all virus infection were all negative. And the pericardial tissue biopsy showed that they have the chronic fibrosis pericarditis, which means it may be due to something of the inflammation of the pericardium led to exacerbate about the pericardial effusion and the heart failure. However, there were no diagnosis of malignancy or some of the pathogens such as cytomegalovirus. And in the pericardial effusion, they did not discover any pathogen from the culture or PCR. However, in the blood, they see the chlamydia pneumonia, the IgG is positive. But I think it may not be the significant pathogen. So in Xinguang Hospital, they also send the pericardial effusion to the NGS study. The pericardial effusion showed that the rickettsia felis, which was from the freer and from cat, and the other is the blood. The blood did not show the rickettsia. So the summary from the Xinguang Hospital doctor's diagnosis, they suggest the pericardial effusion of the rickettsia felis is significant. So they added a doxycycline treatment, and also the patient was recovery very well and received the rehabilitation program at the outpatient clinic. After trace to the family history, the lady would like to raise some cat. So his granddaughter had some cat in the house, and the family had the pet of a cat. So the doctor think the pericarditis may be due to the rickettsia felis. I think it will be wonder for us that we could not imagine about the pericardial carditis with rickettsia felis before this study. So I share these interesting cases for demonstration of the NGS study. So now we enter to the panel discussion. Will you invite Dr. Li欣蓉to the front? Because Dr. Liu Boyu had back to Taichung Brigham General Hospital, so we had one speaker for panel discussion, and I also welcome all of you in discuss together in the panel discussion. 好, okay. So there had 11 questions. So because the time is limited, so we will discuss very briefly, and maybe our audience can enter and discuss together. The first question, I think several questions is similar, so I will combine some of the questions. The first question is about the RNA pathogen, because the RNA is very susceptible to in the environment and decay very quickly. So how is your experience to potential RNA pathogens such as the RNA virus disease if you had a strong suggestion of the diagnosis of infectious disease caused by RNA pathogen? So will you had some experience or the NGS study? Yeah, and Professor Wilson or?
Sure, I'm happy to take a stab at that. So yeah, that is a challenge. I think hopefully that'll be something that as MNGS becomes more prevalent and a more common test that physicians think about ordering, that it'll become more commonplace to quickly freeze, a small volume of spinal fluid or blood or any or prosthetic joint fluid, whatever the relevant fluid type is for potential MNGS. Even if a sample isn't sent for MNGS right away, we've tried to, locally train and encourage physicians to at least think about setting spinal fluid aside in the freezer to make it possible, because that is a real challenge that, especially with RNA viruses, that after 24, 48, 72 hours, that the degradation is quite significant, and that not only limits your ability to detect RNA viruses, but of course impacts the potential host transcriptomic analyses that you might want to run alongside that.
Thank you, Dr. Wilson. How is Dr. Cho? Dr. Cho, how is
yes.
your opinion about the RNA pathogen diagnosis benefit in the MGS study?
Yeah, I agree with Dr. Wilson that the question is correct. The RNA is indeed quite labile. It's highly susceptible to degradation. And so typically for RNA sequencing, we recommend that the sample gets either that you add an RNA preservative, such as DNA RNA shield, which will protect the RNA from degradation, or you freeze it as soon as possible to preserve the RNA. That being said, it actually turns out that extracted, purified RNA is actually more highly susceptible than RNA native RNA, say, in the viral capsid. There has been some data to show, for instance, that you can actually keep, for instance, saliva or nasopharyngeal swab samples infected with SARS coronavirus 2 in patients with COVID. You can keep it actually at room temperature for several hours to days, and for some reason, the RNA is typically intact even after keeping it for several days. So, but in general, because we do worry about RNA degradation, our recommendation is either to add an RNA preservative and/or freeze it as soon as possible.
Thank you, Dr. Zhou. And the second question is about the specimen, because we know the specimen, some may be more viscerally, such as saliva or sputum or some of the mucus. Would there were more complex to be processing a step before analyzing the machine process of NGS? I think it's yes, because some of the specimen may be viscosity be very high, which was not very convenient for the NGS study during the machine process. However, most of the specimen can be used for application to the NGS study. So how is your opinion?
Maybe I'll tackle that one as well. So it is correct that specimens that are more viscous are more difficult to deal with. For those types of samples, what we typically look for is we look for the signal in essentially cell-free DNA or cell-free RNA. So what we typically do for highly viscous or cellular samples is we do a centrifugation step. And occasionally you may also employ a bead beating step. We have found that using like mucinase or enzymatic or proteolytic degradation, it probably doesn't yield it's probably not as, it doesn't increase the diagnostic yield, and it also increases the risk of contamination. So I usually do not recommend that. I do recommend that you try to isolate the fluid or the cell-free DNA or RNA part of that sample in order to be able to recover the DNA from the pathogen.
Thank you. Yeah, also in my opinion, I think the aseptic fluid is more appropriate because the contaminated fluid or specimen maybe had a difficult to interpretation first. And the second is about the cell, because too many DNA or RNA information, especially for the human cell, may be interfere about the validity, but correctity and validity of the NGS study result. Thank you. The third question is about the best timing. I would like to ask Dr. Lee, do you think what is the best timing to utilize the NGS tool in clinical setting?
Okay, thank you. I think that's a very important question. I mean, NGS being very useful tool, but it also is very expensive. And I think for difficult and challenging infectious diseases such as meningitis, I think that is very, very important to use a very highly accurate diagnostic test. And also for cases that are difficult to culture, for culture negative cases, such as in our study, the culture negative cases are maybe often due to either non-bacterial cases or difficult to fastidious bacterial that may be difficult to isolate. I think in cases like that, either it's difficult to culture or very very highly challenging cases, I think these cases are the ones that should be in priority to use these diagnostic tests.
Yeah, thank you, Dr. Lee. Because the following two questions was similar, because the audience would like to know what is the best timing to utilize the tool in clinical setting, and what it is a situation that you will encourage your patient to receive the study of NGS. I would like to ask about our foreign speakers' opinion. What is the best timing, and what is the most indication or situation to recommend the NGS from the clinical infectious disease situation?
Maybe I can speak first, but I'll specifically speak about neurologic patients because I'm a neurologist, and those are the ones I think about all the time. I mean, I think I agree that just in general, the syndrome of meningitis encephalitis is challenging. We're focused here today on infections, but of course there's been a kind of parallel revolution in neurology with the recognition of autoimmune diseases that can mimic what we used to think of as viral encephalitis. And so I'm more and more a proponent of using a test like this very early on in the presentation of an encephalitis. One, because that's when direct detection tests are going to be most sensitive. Two, because even if it turns out to be non-infectious, the sooner the physician can become confident that there's not an infection being missed, the sooner that will build their confidence to immunosuppress patients for what can be, highly treatable, but also very time-sensitive diagnoses like NMDA receptor antibody encephalitis, et cetera. And third, I think it's just very hard when someone comes to the hospital with encephalitis to know whether it's going to be a self-limited infection that someone may recover from quite quickly, or 1 to 2 to 3 days later, if they're going to take a significant turn for the worse and have, a much more aggressive viral or parasitic or amoebic or, fungal infection. So I don't think we need to send it necessarily the first day someone arrives, but at least saving that initial spinal fluid. And if the herpes simplex PCR and gram stain come back negative, thinking really hard about sending it soon. And I think also chronic meningitis patients, I think, are another important population where testing like this can be very high yield. Because again, if it is infectious and it's chronic, the nucleic acid from the pathogen should be around, for the weeks or months that the meningitis is persisting.
Thank you, Professor Wilson. And how is about your opinion from Dr. Cho? I think you must have many experience about the NGS study.
Yes, so perhaps I think Dr. Wilson gave an excellent response for neurological infections. Maybe I can address kind of the non-neurological infections. So that includes respiratory infections, urinary tract infections, abscesses, as well as bloodstream infections or infections associated with sepsis or culture-negative endocarditis. So for these other types of infections in general, this is similar for neurological infections. I typically think of ordering the test not as a first-line test, but I think of ordering it as a second-line test once the first-line tests have been run and are negative. And typically, when we think of first-line tests, I think of first-line tests that can be run locally in the hospital. So these include, for instance, respiratory virus PCR. You may have the ability to set up cultures, and usually within a day or two, you can find out whether or not at least the easy-to-culture organisms will turn out positive. There are some antibody tests that are also run in-house. I think that if those tests are all negative, and you're thinking of sending tests outside to reference laboratories for outside testing, that's when I think there's a role of making MNGS in general as a second line test, because as opposed to more targeted testing where you're sending off for instance, PCR antibody tests for specific pathogens and multiple tests, you could potentially be able to replace all of that with a single metagenomic test. I also feel that there are some indications where the test may have relatively be maybe high diagnostic yield. So the test could be, it's more likely that you'll identify a positive. So for instance, we have a large immunocompromised transplant patient population at UCSF, and certainly probably in Taiwanese hospitals as well. So infections in immunocompromised patients, I think, is particularly high yield for several reasons, as noted also by Dr. Wilson in his talk. Also, in cases of culture-negative endocarditis or fever of unknown etiology, and especially those that are manifesting as subacute or chronic manifestations of these symptoms. In general, then if there's signs of an inflammation or high suspicion for an infection, those are instances where MNGS also has higher yield. Probably the third category is if there is evidence of radiographic evidence of infection. So for instance, a culture negative abscess, evidence of inflammation of a tissue or an organ, in those sort of settings, then there may also be increased yield from MNGS.
Thank you, Dr. Cho. I think the question is very interesting for the audience because when is the timing and what is the indication to send the NGS study? I think it is very important. Would there were any guests from the audience had some comment about the timing and the indication to send the NGS study? Professor Huang, would you have some comment?
Yeah. It depends on the price, the availability of the test. If you can easily prescribe the test and get the results soon, and the test is not so expensive, I believe a lot of physicians will prefer to order the test quickly. If that's not the case, you have to send the test to a specialized lab and wait for the results for maybe 2 days. Then maybe we will go to the traditional PCR first. And also it depends on your setting. If you have a very good lab who can perform multiplex PCR and easily and conveniently, maybe you resort to that test first, and you pick up some special cases like meningitis, encephalitis, which from your experience is very difficult to get the correct diagnosis, and you may put the MNGS as the first-line test for those people. So it really depends on a lot of factors: the accessibility, the price, the turnaround time. I think that will determine whether the physician will prescribe it first or later. And I think the scenario is changing. The situation today will be very different from the situation next year. The test will undergo a lot of evolution, both in the price and also the applicability of the test. So for now, I tend to agree with the opinion from all the experts. We may start from the cases which, from your experience, it's very difficult to get the result, to know the etiology. In those cases, you tend to prescribe the MNGS as the first-line test.
Thank you, Professor Huang. I think maybe in Taiwan we should have our regulation or definition about what is the appropriate timing of the center of study and how is the rationale of the indication for the NGS study. I think maybe we will have a regulation or consensus is very important and necessary in the future discussion. Thank you. The following.
May I make a comment? Perhaps can I just add a comment regarding this? So I'm actually involved, and Dr. Wilson is as well, involved in a consortium. So we're developing a consortium in the United States of experts in MNGS. And the goal is actually to discuss with some of the major societies, including Infectious Diseases Society of America, the American Society for Microbiology, American Society for Association of Molecular Pathology, and as well as several other, I believe, the neurological societies as well. But the goal is to arrive at a series of, to provide essentially a consensus guidelines for, as at least best as we know, for currently for clinical MNGS. And so this is an effort that we're hoping to engage, several societies because this is really what is needed in the field, is that there are no consensus guidelines currently, to my knowledge. And so it's something which is really needed in this field, and we would certainly welcome input from Taiwanese societies. If you're interested in this effort, I can provide you some more information. And but we'll be having a series of meetings over the next year. And hopefully we'll be able to draft a series of consensus recommendations, based on the most current data that we know of regarding MNGS.
Thank you, Dr. Cho. Is there any comment from this issue from the audience? Okay. The other question is about the economic cost. The question is, in the United States, what is appropriate and how much the patient would need typical to pay for NGS testing and analysis before the unknown resources of infectious disease. So this is about the economic cost. How much and what is the rationale of the payment for the NGS test in the United States for patients with unknown sources of infectious disease? In Taiwan, I remember about 1,000 US dollar, 30,000 NT dollars a test. So how is it in the United States?
I think it varies, but typically, Dr. Chu can correct me, but I think typically it's around $2,000 to $2,500 US dollars in the for a test, and most of the patients, at least that are billed by the UCSF clinical lab, are in the hospital, and and so the insurance is not directly billed, but rather the hospitals are getting paid by the insurance company to take care of the patients, and then the hospitals decide that from that hospitalization fee they're going to pay for the test, whether it's and that includes patients who are being seen at hospitals in other states who decide to send the test to San Francisco. So it's not that insurance is never billed directly for the test, but a lot of that, and Dr. Chu is more of an expert on the where this stands, but a lot of that direct insurance billing is still being worked out on a national level. That's not as advanced, I think, as it sounds like it is in Taiwan.
Okay.
Yeah, Dr. Wilson is correct in that one of the big challenges for us is that the test is not FDA approved in the United States. I and others, and we've been engaging in efforts to obtain FDA approval, but in the absence of approval, essentially the test is being run as what we call a laboratory developed test in a clinical CLIA laboratory, and for that. The billing for mostly the test is run, the vast majority of patients, the test is being run on hospitalized patients. And so as a result, the billing is to the total cost of the hospitalization, which typically represents a very small percentage of the cost of the test. About $2,000 represents a small percentage of hospitalization costs, especially for patients who have meningitis and encephalitis, for instance. And so it's much more challenging for us to get reimbursement for outpatients because, as I said, the test is not FDA approved. So if we send off the test for an outpatient, we have to basically submit a form to petition the insurance company to actually pay for it. And our success rates have been, fairly low, maybe about 30% of the time the insurance company will pay for it. But part of the reason is because the test is not FDA approved yet in the US.
Thank you, Dr. Wilson and Dr. Cho. Yes, because in Taiwan, I think now the NGS is paid by Lancel. That means by cash. So if we can have a more clear and a very important indication, I think we can apply about the national health insurance payment. That think maybe help some of the patient to more known about the direct diagnosis of infectious disease. However, I think it should be very considered to have the indication for national health insurance. I think this may be the last question. So for your opinion, because the host response and the host factor may be different. For example, the children versus adult and the viral infection versus a bacterial infection. So how will you to define or identify the biomarker for infectious disease, such as the PCR or antigen test before the NGS study? Yeah, I think this is maybe different thinking process of the diagnosis. If you had a more narrow spectrum or known possibility diagnosis, such as a viral disease, we can use a PCR or viral culture. However, you may consider the variation of the host or immunity or the timing before had the result from the study. So I think it should be considered whole of the picture of the host pathogen and the environment. So how is your opinion to have some position about the PCR, antigen, and the NGS study? Well, Dr. Chu had some
Yeah, I can
comment?
answer the question. I can answer the first part of the question, which is regarding the host response classifier. So one thing is I do acknowledge that indeed the questioner is correct in that individuals vary significantly. You have children versus adults. You have immunocompromised versus immunocompetent patients. You have individuals who have comorbidities, especially those who may have kind of immunodeficiencies that may affect the host response. That being said, one thing I should mention is that in our host response study, roughly about 30% of the patients were immunocompromised. Many of them were solid organ bone marrow transplant recipients. And at least with respect to those category of patients, we did not note a difference in the host response between immunocompromised patients who had at least they were treated disease or well-controlled disease versus immunocompetent patients. So it was actually quite promising that the host response appears to be remarkably consistent between immunocompromised and immunocompetent patients. There were some exceptions. Patients who had very severe immunodeficiencies, such as patients with SCID, for instance, those patients did have a markedly altered host response or no host response at all, which would make it difficult for us to diagnose those infections in those patients using host response. But that was a very small minority of the group. And I should also mention that roughly about 20% of the patients in our study were also pediatric patients. And we saw that at least among the different categories of infections, viral, bacterial, fungal, and parasitic, that we did not we found that they had similar profiles between children and adults.
Now, I'll echo, I think I presented last year a study that we did with a few hundred patients enrolled in Uganda. All in the whole patient population had HIV, and many of the patients had advanced HIV. And in that study, the host response goal was to develop a classifier that discriminated between patients who had tuberculous meningitis and those who had non-tuberculous infectious causes of meningitis. And it was heartening that the most explanatory genes whose expression levels, discriminated between those two groups. At least two of those genes were actually parts of other host classifiers related to tuberculosis infection in the periphery. And those classifiers were developed in populations of patients that had very low incidence of HIV. So I think that was a surprise, a welcome surprise to us that, again, in these patients, many of whom did not have much of a pleocytosis in the spinal fluid, again, indicating, how advanced their HIV was, that even in those circumstances, the host response was, and even though we were looking at a different body compartment, the host response kind of echoed what independent studies had seen in blood and immune competent individuals.
Thank you, Dr. Cho. Yeah, please.
Oh, but of course, I think all these classifiers, there's no doubt that they get better with increasing numbers of patients and more diverse patients. They're these are, I think, really promising initial results, but they're only going to be strengthened with additional cases being added.
Thank you, Dr. Wilson and Dr. Cho, and thank you for your discussion, and Dr. Lee and Professor Huang for your participation. I think time is limited, so we would like to move to the closing remark. Thank you.